Hi everybody, welcome. Just as we're letting people in, it's hard to believe that we've actually got ourselves to the last of the series of 5 webinars. It's somehow, I can't quite believe that we're in April. This webinar today is a real team effort. We have talked across the different settings. We've talked in the different organisations. We've talked all together about actually after the intensity of the palliative care input that we've done over the last 4 webinars, the final thing that happens, the death of somebody, how it's approached, what needs to happen, can actually sometimes be a really surreal moment that actually people are not necessarily too sure about. And the difficult thing is that for families at that point of view, this is a really vulnerable and particular time, and they will remember the smallest things because everything is so heightened, as you know. So we've really gathered together all of our thoughts, and you're going to hear from the whole of the webinar team really as we go through the next hour. Each person's got something slightly different to add to the story and to cover what we hope is most eventualities, and we hope it's going to be a really useful hour. We will stay on though. We'll record the session as now, but we will stay on for another half an hour after the webinar has finished, just in case people have got particular questions or queries. But as we've always said, please be aware of patient confidentiality, so no patient names and no colleague names, no team names. But if there are things that would be helpful to discuss, then this is an opportunity to do so. I think just the one other thing to say is that, as with any session of this kind, everybody is doing different things in their non-working world and managing different situations. So as part of the final slides around bereavement, there are some signposts that we give to patients, yes, but actually they're quite useful for ourselves as well. So I hope that this session today is useful. I hope it doesn't trigger anything difficult for you, but please make use of the resources that we put together if it does. So without more ado, I am going to just do the next slide. If we could have the next slide, Joe, just to say these are the things that we wanted to cover based on people's comments and suggestions. We thought it would be useful to look over actually what needs to be done at the point that somebody takes their last breath, but also to think about afterwards, to think about grief and bereavement. There are some new ways of thinking about grief and bereavement, and also to acknowledge that the last 2 years have been extraordinary, and coronavirus, COVID-19, has changed some of the patterns of grief and grieving that we will all be dealing with. We will all be seeing the result of that. So that's what we hope to do. Next slide, please. We hope. So hopefully, Joe, can we move on one more? Oh, and I think, great stuff. Okay, so the first thing I'm going to do is I'm going to hand over to Emily, and we're going to talk about what happens just if that is expected. So Emily, I'm handing the mic on to you.
Thank you. Hi, my name's Emily Johns. I'm a GP in Rumney Surgery. And as Fiona said, I'm going to speak very briefly about what to do when someone dies at home and the death is expected. I think it is important that we explain to loved ones what to do when someone dies at home, just to make the process as easy as possible for them. From experience where people haven't been quite sure about who to call and what to do, they end up making lots of phone calls and getting more and more upset and distressed as events unfold. So I think if we are expecting someone to die at home, if we can just let them know who to call and when, and hopefully they should have a much easier experience. Next slide, please. So Jean is a 75-year-old lady with end-stage pulmonary fibrosis, type 2 diabetes and osteoporosis. Her preferred place of care is home, and she's well supported by her family, a care package, district nurse and GP. She takes her last breath at 10:30 in the morning. So I don't know if you want to join in on the chat and just pop some suggestions in as to what you think the family need to do, who they need to call, and who might be best placed to come in and help them at this time. Just give you a few moments there. Okay, and if we can have the next slide, please, Joe. So Jean has lots of health conditions. Her preferred place of care and death was home, and she's been well looked after in her final days, and she was an expected death in the community. So I think the first thing to tell friends, family, loved ones, that when someone dies, there isn't an immediate rush to do anything. Family and friends can spend time with their loved one, and only when they feel ready, they need to inform someone. And if the death happens in hours, so usually between 8 in the morning and 6:30 in the evening, then the first port of call would be the person's GP. And the GP can then come and make a formal verification of death, which involves a brief examination of the body. A useful person to call as well is also a district nurse, especially if they've been involved in the person's care. They can come and remove any equipment that's in place, for example, syringe drivers, but also if they've been visiting the person, they know not to visit the person first thing in the morning, but also the district nurses provide a bereavement visit as well. So it can be useful to inform them when a person has died. We can also use I advise the family to call a funeral director who will then come and collect the body. Something we should bear in mind is that everyone's wishes about how their body should be cared for, and including any religious and cultural practices, should be carried out as far as possible. So once the death has been verified by the person's usual GP, they can then certify the death by completing a medical certificate of cause of death. This is then sent to the registry office, and a registrar can then issue a death certificate and certificate for burial or cremation. Next slide, please. So so that is how things would go in hours. Similar situation, if Jean were to take her last breath at 10:30 at night, the process is just slightly different. If we could have the next slide, please, Joe. So if the death occurs out of hours, again, there isn't any immediate rush to inform anybody. Only when loved ones feel ready, they can then contact out of hours. If the death occurs after 6:30 and between 6:30 at night and 8 in the morning, it will be the out of hours service who will be their first port of call. Some patients who are end of life will have contact details for out of hours already given to them, but most GP surgeries will have the out of hours telephone number left on their answer machine, so they can call their usual GP and get the number if needed as well. Alternatively, NHS 111 can give advice on what to do next if a person has died out of hours. The out of hours GP can then come and verify the death, and a notification will be sent to the usual GP. With the verification, it's normally done by a GP, but it can actually be done by other healthcare professionals. Some district nurses are comfortable in verifying death, and some paramedics can as well. Again, advised to contact district nursing if they're involved in the person's care or if there's any equipment in place, and again, the funeral director. Most services, most funeral director services do run a 24-hour service, so the body can be collected. The person's usual GP will have been informed of the death, and then they can complete the medical certificate of cause of death. Out of hours wouldn't complete any of this paperwork. It would have to be done by the usual GP. And in some circumstances, the person's usual GP may need to view the body after death, but I think we're going to discuss that a little bit later on. And again, the death is registered in the same way through the register office, and a death certificate and certificate for burial or cremation can then be issued. So I think I'm now going to hand over to Dr. James Davis, who's going to discuss what happens if there is an unexpected death in the community.
Thank you. Sorry, just checking. There were a couple of slides. Is this sort of the intro slide to it? Apologies, Charlotte.
It's me, James. It's Joe. I'm controlling the slides. This is just the next one. Do you want me to go to the next one?
Yes, please.
Okay.
Fine. Yeah. If we can go. So this is sort of a whistle-stop tour of what to do. So obviously Emily's just gone through what to do for an expected death at home. So this is if there's somebody who actually, death wasn't imminently expected to happen, what the sort of broad outline of what we should be thinking and how to approach that, because that can be quite stressful, both for for loved ones, but also I think for us as well as healthcare professionals, is who do you contact and what do you do. So if we can go to the next slide, please. So yeah, so first of all, I mean, I'd sort of contacted someone from WAST, who is the Macmillan paramedic with WAST, as to, because obviously they've got probably more experience than we do in palliative care, because most of the patients that we see actually are going to be expected deaths. Even if it's a more rapid deterioration than expected, it would still come under an expected death. So I approached them just to see actually what their protocol is, and they're in the process of putting something specific together. But essentially, if you can't gain access to a house and you think that somebody is acutely unwell inside, then part of it's sort of common sense that actually you're going to try and contact the people that you can to gain access, and also to get more information, because it may be that actually they've gone away on holidays, or they've gone somewhere, or there's a reasonable explanation for it. But if you can't gain access and you're worried that actually someone's acutely unwell or even died in the home, I think then it's a question about what you're going to do, what the urgency is. If it's someone who actually, is under palliative care but is having very active treatment and acute hospitalization would be appropriate, then actually you're going to need to dial 999. And then it's probably going to be a combination of police and ambulance that come, the police to gain access, and then the ambulance to obviously assess the situation and see whether, if the person is alive, whether they go in. If you feel actually it's somebody who, although you weren't expecting them to be acutely unwell at that time, that the general trajectory is that they're deteriorating and that going to hospital wouldn't necessarily be appropriate, then you can dial 101, which is sort of the emergency services non-emergency number. Now that sounds like an oxymoron, but the non-999 number. And if then you gain access to the property, or you actually get into the property and someone has died, then it's to phone 101 and to talk through the situation. One of our senior nurses had a situation where actually there was somebody who probably wasn't predicted to die in that week, but actually wasn't, and it wasn't a shock that they had died. So she phoned 101. They then sent the police to gain access, and then sort of took things from there. Next slide, please. So if it's an unexpected death, then what tends to happen is the police will oversee sort of the process. And the next step in that process is actually, is this suspicious? Is there something where actually a coroner needs to know about what's happened? And that may be either because the death is unnatural, or actually there are circumstances which mean, for example, that a medical certification of the cause of death can't be given. And if a post-mortem is needed, the body's probably going to have to be moved to a hospital mortuary, which would likely be UHW in Cardiff and Vale. But what they would try and do is that even if it's not, it wasn't predicted that person was going to die that day, but there's a reasonable reason why this person would have died, and there's no other evidence of suspicious circumstances, is actually try and speak to somebody about getting the medical certification of cause of death, usually the GP. And if that's possible, then if the person has family and friends, then they can go ahead, as Emily's discussed, about making funeral arrangements. If there's no family or friends, even if it's expected death, so the death is expected, then they'll usually go to the mortuary at UHW. Again, I've repeated that if there's post-mortem, they'll go to UHW. So the main sort of headline is, if you can't gain access and somebody would go to hospital and you think it's appropriate and you're worried about them, then it's 999. Otherwise 101, and then it's obviously going to be individual to that person. Next, please. I think there we go.
Thanks, James. So over to me then, Jo Hayes. I am working with the community palliative care team over in the Vale, just to talk about death certification from the family's point of view. So we have probably got a mixture of GPs, GP registrars, district nurses and staff who work in either hospices, social care or nursing and residential homes on this call. Certainly for those of you who are GPs and GP registrars, the guidance on this changed 2 weeks ago, and you probably do need to just read up. But an attending doctor, if somebody has died in the community or in a hospital, will need to complete a death certificate, also known as medical certification of cause of death. The certificates can still be emailed to the registrar if you're a GP surgery or in a community setting. Informants need to attend within 5 days, and that's now changed to in person because COVID arrangements have ceased. So somebody needs to go in person to register the death. And as Emily said earlier, informants would then receive a certificate for burial to give to a funeral director or an application for cremation there. And on the right-hand side there's some really good stuff on the gov.uk websites about when somebody dies and what to do on a step-by-step process. This is guidance that covers both England and Wales because the law is the same in both of those countries. And it also talks you through things like number 3 there, tell us once, which is how to inform all of the government agencies that somebody's died without having to tell every individual bit, without having to tell sort of benefits and pensions and everybody separately. There's also information there about whether you can have access to bereavement benefits if you're someone that might need help to arrange a funeral for a loved one. And then stuff about probate and dealing with the estate. So there's if you click on the arrows there, there's loads of information on there. So that's potentially helpful for families. From a healthcare professional point of view then, there's info in the front of your medical certification of cause of death book. And the death certificates are really important to tell loved ones, what somebody died of, why they died. And also you need the form legally to allow death registration and all the formal tasks to take place, such as funerals, burials, and to settle the estate and things. It's also potentially important for families, if there are hereditary medical conditions and that sort of thing, and it informs all the OC&S data about, what the main causes of death in the country are, and will have informed all of the COVID registries in the last couple of years. So as I said, the special guidance that was put in place during COVID, which, for example, allowed people not to have to register deaths in person, has now been replaced with guidance from 2 weeks ago. And on the bottom right there's a link to the new guidance for doctors. There we are, and death certification is of a statutory duty of an attending doctor who must have seen a patient within 28 days prior to their death. So seen can mean by video, but my reading of this says that seen cannot mean telephone, but could potentially mean other healthcare professionals within, for example, a primary care team. So please do put in the chat if you know differently, because I'm not a GP and not normally doing certificates from the community. And if someone could monitor the chat, because I can't see it, let me know if people have got specific questions or more like information from doing this themselves. So yeah, if you're a doctor or a GP registered, if you're a doctor or organising this sort of stuff within a primary care setting, then I would urge you to read the new guidance. Okay, so death certificates, for those of you who are used to seeing them, or those of you who might not be used to seeing them, are in parts. So 1A would be the main thing that's actually caused that person to die. So in this case, it's a hemorrhage of some sort. But the next one down there will be the thing that's caused the hemorrhage, and often written in quite a lot of medical jargon. So sometimes needs some explanations to families and loved ones, but that means sort of a secondary in the liver has burst really and caused a bleed. And why was there a secondary in the liver? Because this person had cancer of the colon. So it's one thing leading to the next thing, leading to the next thing that's caused that person to die. And then in part 2, it's something that's a significant condition that might be contributing, but it's not directly related. So in this case, diabetes. And then down the bottom there, the cause of death, cerebral infarction, is sort of medical jargon for a stroke caused by a thrombosis of one of the arteries in your head. And that in turn is caused by having cerebrovascular disease. So, you know, arteries and your cerebrovascular in your brain furring up a bit. So that's how medical death certificates are written. And as I said, can sometimes need some explaining to families. Okay. Just a letter from the coroner. So we're South Wales Central in terms of coroner areas. And this was sent out a couple of weeks ago, as you can see. So in a nutshell, the easements made under the Coronavirus Act have ceased. Basically, it's as it was pre-March 2000, apart from there's an amendment to say that you need to have attended within 28 days rather than 14. And the doctor issuing the certificate must have treated the deceased within their last illness within the last 28 days or seen the body after death. And our coroner has also clarified attendance here. So as far as attendance is confirmed, I adopt a pragmatic approach and would not have an issue if the last attendance was undertaken by a non-doctor ANP or advanced paramedic, provided that the certifying GP had discussed the last attendance with that person. Then our coroner has said that he would feel that was sufficient. Okay. What deaths need to go to the coroner? And we haven't got very much time, so I've just quickly pasted the guidance there. This is from the link that I gave you a couple of slides ago about the updated regulations. So you need to refer deaths to the coroner when you think that they were unnatural, unknown, violent, or in custody. If it's due to the person undergoing a treatment or a procedure, if you're concerned about neglect or concerns about care, and that may bring them into the orbit of the coroner. That doesn't mean just because the coroner is involved that there will be something like a post-mortem. Often you'll just need to answer a few questions or fill in some paperwork, and then you'll be able to issue a certificate. If you don't know a cause of death, then that would need to be referred to the coroner. And if no doctors attended the deceased or the certifying doctor has not seen the deceased within 28 days prior to their death. And again, this is directly pasted from the guidance. This can include video consultation, but not telephone or audio. And if the deceased was not seen in person after death by the certifying doctor, then that death needs to be referred. Okay. So as doctors, we're under a legal obligation to refer if we feel that death should be referred to the coroner, and would be in trouble with the GMC and the law if you chose not to refer when you knew that there should be a referral made. As I said, it doesn't necessarily mean that there would be a post-mortem, it just means clarification. And the coroner needs to be satisfied that you're in a position to issue a certificate. Okay, and coming soon to a surgery near you. So the medical examiner service, again, pop it in the chat if you know more than me, because I'm not quite sure what the time scale is of rolling this out to primary care in our area. But I work in the Marie Curie Hospice in Penarth, so just outside of Cardiff. And we have been referring our deaths to the medical examiner service for the last 2 years before COVID. So what that means is that when somebody dies in the hospice, we let the medical examiner officer know that this person has died. We send them a copy of our notes and we say, this is what we are proposing to put as 1A on our death certificate, 1B, 1C. This is what we propose to put in 2. And the medical examiner will then look through our notes, contact us back and say, I agree, or I think this should be amended to this. They'll also liaise with family. They'll also take feedback from family about if they've got any concerns about care. And the good thing for us in the hospice, fortunately, is we get lots of complimentary feedback through the medical examiner service about care for patients who have died with us. It's been created to allow greater scrutiny of deaths and to hopefully improve accuracy of death certification. I think I will leave that there if that's okay and go on to our next slide. Oh, sorry, I just need to run through the practicalities because I think Fiona's been called away. So we've talked about a lot of this already. So verification of death is confirming that someone has actually died. It's often done by doctors, GPs and out of hours GPs in the community, but may well be done by suitably trained other healthcare professionals. And in lots of areas, district nurses are verifying death. Obviously, our paramedic colleagues can also verify death. So there's often arrangements for returning equipment, and it can be really difficult with bereaved families to have sort of, you know, an empty hospital bed in their lounge and things. That's often something that they do want to get rid of as soon as possible. So liaising with the district nurses or dialing the number on the equipment is often helpful in order to do that. And as palliative care teams, we can advise people on that as well. There's a number for oxygen there to get that taken away again. Medicines, so you do need to safely dispose of medicines. Often the palliative care patients would have lots of controlled drugs in the house that as healthcare professionals, we've got an obligation to try and dispose of as safely as possible. So return them to a pharmacy, and I am reliably informed every time I ask that that can be any pharmacy at all. It doesn't matter if it's the one you normally use, it doesn't matter if it's the one where the drugs came from. I have heard some instances of pharmacies not wanting to take medicines in because it's quite a lot of work to destroy things properly, but they are supposed to take medicines from people and destroy them in an appropriate way. Okay, so informed care agencies, funeral directors, we've already talked about. We haven't talked about religious issues and rituals, and I don't think I've got time to do that particularly now, but it is good practice for all of us to explore that with families during the run-up to a person dying, really, and to be realistic about what is and isn't possible. For example, in the Vale of Glamorgan where I work, unless anything has changed very recently, it's not possible to register deaths out of hours. And therefore, for some people with particular religious beliefs, so Jewish, Muslim patients, some traditional families would want people to be buried as soon as possible and within the same day, and that's unfortunately not always possible. We've talked about tell us once, which is how to inform government agencies, bank accounts. The banks are really useful in giving information about that, and people may already have lasting power of attorney for finance before someone's died. We will run bereavement services, and there's various bereavement services available, which we're going to discuss later in the talk. And, you know, communication, as ever, is paramount. So I'm going to move on to my colleagues from City Hospice, who are going to talk a little bit about benefits and allowances, if that's okay. Are you there, guys?
Yes. Yeah. Hi. Hi. Hopefully you can hear us because we both got our masks on still.
We can hear you. Do you want to put your camera on?
Is our camera on?
Yeah, camera's on.
Yep. Is that all right? Okay, hi, so it's just Leanne and I from City Hospice as the welfare rights officers, just to give a bit of information of what support that we offer to families to help with any stress and financial burdens during this difficult time. So I mean, things have already been touched upon regarding registering the death and Tell Us Once service. So it's just perhaps what we would inform families is that, as already been noted, that the legislation has changed now from the 25th of March. So when the medical cause certificate is passed to the registrar, they will then call the next of kin and arrange a face-to-face appointment. So it's at that appointment then the families get to register the death. They'll be provided with a death certificate. They will also be provided with a unique reference number. And it's that number that families would use then in contacting the Tell Us Once service, either by telephone or on the Gov website, to update them of the change of circumstance. So once they do the Tell Us Once service, it just filters the information through to all relevant departments, whether that's the DVLA, Passport Office, local authorities, and then Social Security benefits. So following that action, all benefit claims then would be suspended or shut down. So it's then, we would then provide advice regarding what benefits someone may be entitled to now as a single claimant. So the first one that I've kind of highlighted is that we'd look to give advice due to under state pension age or over state pension age. So if we're helping someone who's under state pension age, if they are married, which is one of the stipulations, is that they would be eligible for a bereavement support payment. So if they are married with no dependent children, they get a lump sum of £2,500 and then £100 a month. This is paid then for 18 months. The higher rate is if they were married and had dependent children, they then have a lump sum of £3,500 and then £350 a month. So there's a bit of a difference, obviously, between the different rates. Currently, we're waiting as welfare rights for legislation to be implemented, because there was a recent case at the Supreme Court, which this bereavement benefit is only available for married couples at the moment, but the legislation hopefully will be implemented soon, which will allow it for cohabitees, so obviously unmarried, but if there's dependent children, they will then be able to access this benefit. Under current legislation, it's not available, so we're looking for that to be done quite soon. As well as that, then I think it's to introduce the surviving spouse to claim other benefits. So it could be that they were claiming as a couple, perhaps universal credit. That would change, but they would be entitled to a 3-month run-on of receiving the same amount as a couple rate. After that 3 months, it would then drop down to a single rate of income. So it's to give people a bit of a buffer, I think, to hopefully help with budgeting going forward with their finances. If people were claiming benefits, what we call old legacy benefits, those claims would then be shut down, and that would then mean a transition to the universal credit, which we would then help to practically claim then. Also, if we're helping someone who was a carer and was claiming carer's allowance, whether that's looking after their husband, wife, mum or dad, they would still be entitled to that payment of carer's allowance for up to 8 weeks. So I think sometimes it's important to let people know that. We also get in touch with carer's allowance to let them know about the person passing away and that that person's still entitled to that 8-week run-on. One other thing as well that we may direct people to is the Cardiff bereavement services. So again, they would be able to provide information for families regarding funerals, benefits available. But they also link with White Rose Funeral Homes to provide low-cost funerals. So sometimes that's also a channel that we like to explore with families. So I've just discussed some of the benefits for under state pension age, and then Leanne's going to help to discuss the rest then.
Okay, so for anyone who was over state pension age, there's no bereavement benefits as such. There's no longer a widow pension, it's been replaced now. So when you notify the Tell Us Once, it should automatically notify the Department for Work and Pensions, and then they would relook at the state pension. So anybody who's state pension age and receiving a state pension, they would do what they call a conversion. So they'd look to increase the pension from the spouse's entitlement. So they'd inherit a certain amount of their state pension. They do this automatically, so they don't need to make an application for the pension. They'll do it either from the Tell Us Once, or if somebody called through directly to the pension service, they would then look to amend their pension. There's no set amount that they'd be entitled to, because all state pension is different. People have additional state pension, and they've also got pension sharing orders. So if somebody was divorced, they'd still be able to inherit some of that state pension if the judge had awarded a pension sharing order on that pension. Both are state pension age and under state pension age would both be eligible for help towards the cost of the funeral. So if they were receiving an income-related benefit, they would be able to apply for something called a social fund funeral payment. This is income-related, so it does look at the overall household income. Anybody can apply for this, whether a relative or a close friend of the family, if they're in receipt of what they call a qualifying benefit. There is a list of the qualifying benefits on the gov.uk website. If anybody needs that information, we can send that over to them. They must apply for the social fund funeral payment within 6 months of the funeral. They can apply for it immediately, just to let the funeral director know that they're making the application, just so they're not chasing them for payments. And they'll know then that the DWP will make that payment directly to them if they've not put any money down firstly. If they had paid any money towards the funeral, then obviously the money paid by the DWP will go straight to the person who's made the application. They also cover things with the social fund funeral payment. They cover things such as burial fees, obtaining medical references or reports, travel costs to arrange and to attend the funeral, and other funeral expenses, including the coffin, the cars, funeral directors' fees, and flowers. They normally ask if they're claiming for the flowers, that the funeral director's fees can't be over £700, because they'll only pay up to £700 for those additional costs. So also, when living together in rented accommodation, they'll need to notify the housing association and the social house. With the housing association and social housing, they freeze the rent for a year. And we can look into helping them with housing benefit and succession of tenancy if there's children in the house. Anyone who's living in the property who needs to take over that tenancy. Going back again to the funeral costs, if there's nobody available to cover the cost of the funeral, or if there's no other relatives who'll be able to step in to pay the cost of the funeral, then there is a public health funeral. And the council do have a duty to do this under the section 46 of the Public Health Act. So they will arrange then a public health funeral for that person under that act. I think I've covered everything. But obviously, if you do have any questions, by all means, please pop them in the chat box, and we'll get back to you. And I'll just hand over now to Elaine. Thank you.
Hello, thank you for that. What I'm going to discuss now, next slide, Jo, is looking at bereavement, and just to discuss basically the impact of bereavement on families, and thinking about things to consider when we're caring for families in end of life. Can I have the next slide, please, Jo? I've put a few objectives down, which we'll kind of touch on briefly. First of all, I'm going to define bereavement, loss, anticipatory grief, and pathological grief. We want to identify common reactions to grief as well. I'll touch briefly on the models of grief and talk about them. we're going to look as well at complicated grief, looking at vulnerable groups, and then talking as well about bereavement support and resources available. Next slide, please, Jo. Thank you. So I've got a few definitions of bereavement and grief there, but there's a lot written in the literature about bereavement and grief. I mean, bereavement is something that most people are going to experience, but how everybody deals with it is different. Grief, it's an emotional reaction to bereavement if anybody suffers a major loss. And again, how people experience grief depends on a number of factors as well. Next slide, please, Jo. So going on from that, looking at common reactions to bereavement of grief. So thinking about emotional reactions, that can be things like depression, anxiety, guilt, anger, loss of enjoyment, relief. Some people experience relief now that the suffering of the deceased has ended. So there's quite a range of emotions that people experience following a bereavement. Thinking about behavioural reactions, these can be things like agitation, fatigue, crying. Crying is the one that we associate more with people when they're bereaved and suffering from grief, because you can physically see that they're sad and they've got the tears as well. Looking at some attitudes, there might be things like low self-esteem. There can be feelings of hopelessness, sense of unreality, suspicion, and social withdrawal. Some people just totally withdraw from social events or just want to shut themselves away. And then there can be the physiological reactions. So things like people might lose appetite, there might be weight loss, weight change, changes in their sleep pattern. So there can also be physical components such as headaches, muscular pains, indigestion, shortness of breath. Some people start to drink a bit more alcohol or start to smoke a bit more as well. And some people become more prone to illness. And these might be some reactions that, say, for instance, a GP would see with people going to visit their GP maybe a number of months or a long time after a bereavement. So there are lots of things to look out for following bereavement and grief. Next slide, please, Jo. Now there's some models out there, models of grief, but the models really provide a framework for understanding what the bereaved people tell us about their experiences. And looking at all of these models, I won't go into them in great detail because I don't think we've got a lot of time to discuss them, but I think it's just worth keeping in mind that everybody's unique and everybody will deal with a significant death in their own way. So there's no right or wrong way, and there's no one model that fits all. So sometimes a combination of the models help. The one that I'm more familiar with, just going back to my nursing days and the early days of training, is Kubler-Ross model. And she goes through the 5 stages of grief and things like denial, anger, bargaining, depression, and acceptance. And this model's criticised as well because people don't follow through these in certain stages. So people go through stages in different ways as well. So it was just really to give you a brief outline to consider there is models there, but there's no one model that fits them all. Next slide, please, Jo. And thinking about complicated grief, there's a number of factors associated with complicated grief. So things like it could be situational. So looking at the death or illness of the family member, how distressing was that for them? Did they have any other stresses at the time of when the person was dying? So just looking at the situation as a whole. And then you've got individual. So what does the meaning and the nature of the loss and the relationship to the person mean? That can also have an effect on how they grieve. So for instance, sometimes like a loved one, if it's a spouse, it might have a more effect on them, and depending on that relationship they have with them. Looking as well at the individual, if they've got any previous physical and psychological health needs, that can have an impact on how they grieve, because they could have complicated grief as well, and just an individual's personality and coping style. And social is thinking, which we've talked a lot about earlier, is the quality of support that people have and what they're aware of what is happening as well. On the right-hand side there, I've highlighted a recent survey that was commissioned by Marie Curie. And it was a survey that interviewed a total of 8,077 adults in the UK. And it highlighted a lot of the issues that we talked about as well with COVID-19, and how attitudes to dying have changed, and how the situation and people have died, situations and where people died changed. And they made a number of recommendations in that document as well, which I think it'll change the way that we support people going forward. Next slide, please, Jo. So how do we assess complicated grief? So looking at the intensity and the duration of feelings and behaviour. So there's a considerable variability in the rate at which individuals adjust to bereavement, and the literature supports that Western societies, most bereaved return to normal level of functioning 1 to 2 years after their loss. Grief-related distress is generally highest in the first year following the loss, and although elevated rates of distress can persist for more than 2 years, and prolonged, intense pining, self-reproach and anger are danger signals, as is prolonged withdrawal from society. And thinking about in the UK, the norm is to keep feelings private, and men in particular may experience social pressure to suppress their emotions. And also thinking, it's important to think about how individuals cope and their personality. Some people will have challenges, and some people don't normally express emotions dramatically, and they're self-contained or private. And I've also put again about COVID-19, because there's quite a number of studies out there looking at COVID-19, because people, I think, are going to have some complicated grief around how their loved ones have died and not being able to see them at the end, and not having that social contact afterwards as well with the funerals. So quite a lot to think about when you're assessing complicated grief. Next slide, please, Jo. I've put a slide in to think about some vulnerable groups that we need to consider. And children's needs and understanding will be affected by many factors, including their previous experience of loss and how these were handled. And it's also important to consider the age and the developmental level of the child. So children begin to develop an understanding of some aspects of death and bereavement as early as ages 2 or 3. But by the age of 5, over half of children have a full understanding. And by the age of 8, all children will. But I think parents are the best people to talk to their children, because they might need some support and professional assistance with that as well. Twycross in the literature talks about approaching the parent as a colleague, as they've got expert knowledge about their children. And I think that's a good thing to consider in palliative care, that parents know their children best and they know how they're better able to cope with things, and then we can provide the support if needed. Confused elderly and learning difficulties. There might be difficulties with having repeated explanations when somebody's dying, but the literature talks about just involving them in important events, such as the funeral or visiting the graves, and these can sometimes help. I know when I'm nursing people at home, and say there's a spouse who has dementia, I always think they're better able to accept what's happened when they're involved in the care of their spouse, because they can actually see what's happening. Next slide, please, Jo. So thinking about bereavement support, and it's really important to support people after. I mean, the terminal illness, it's a stressful period it's a stressful time to the family. And I think we should be looking at the family and the patient as one unit, especially in the final days and the last days of life. And also attending to the family's concerns about the patient's conditions and care. And that's about having the open discussions and communication, just providing reassurance. If there's any misunderstandings or disagreements about the care, if these are ignored, then that can have an impact on bereavement afterwards. And also providing that emotional support, because the families are going to be there to deal with it afterwards. And I also think that we touched on earlier about the practicalities. So I think if you provide information about how to register the death, talk about grief, what support services are available, I think it can be really helpful. Next slide, please, Jo. There's quite a lot of bereavement resources available out there. I've kind of highlighted a few of them. We've got the CRUISE, the National Helpline, and I've just taken that from their website. I've also taken the Marie Curie Bereavement Support Service. That's a national bereavement support service and is available for anybody to call, and it's a national helpline. I've also highlighted our colleagues in City Hospice, because palliative care teams have access to their own bereavement support services. And I've looked at the City Hospice website, and there is a contact number there as well. So there's a number of different resources out there for people to access for bereavement. Just to mention as well, a lot of community groups and churches, they also provide a great support for people after death as well. Next slide, please, Jo. Yeah, and just to conclude, really, there's a considerable individual variation in experience and expression of grief. And just to remind us that grief's a normal response to a significant loss, but some people do need a bit more support and just need a bit more understanding around the processes of grief and how we can support people afterwards. Thank you.
Great, Elaine, thank you very much indeed. And I would very much echo your resources slide. So particularly during COVID, the CRUISE organisation were really clever at pulling together resources for grief, particularly with the mental health issues that COVID produced anyway, irrespective of death and dying, but also the social isolation side of things. So as a useful signpost, I would thoroughly recommend the CRUISE website, particularly around the COVID angle. So we've had a whistle-stop tour from everybody really involved in the webinars on this really, really important topic. I'm just going to bring James in a moment. Before I do, please don't forget to use to evaluate, and please look at the webinars and the recordings. James, do you want to come in?
Sorry, Phil, just two really quick points. The first is just to let you know, in Cardiff, there is a service between 9 and 12 on a Saturday and Sunday working out of City Hall, where there is a registrar who can register deaths for religious reasons. The issue is actually getting the medical certification of the cause of death, which the out-of-hours service won't do. So the only way around it is if it's predicted and there is a GP who will do a certificate on the weekend. But if you contact the registry office, they should be able to give you those contact details. And when we've done it, it's worked really well, actually. Second, just quick point is that actually for City Hospice, you don't have to be known to the team, as in we don't have to necessarily have looked after the patients if they're Cardiff residents. Then we will accept sort of almost self-referrals. Well, we will accept self-referrals from people in Cardiff.
Thank you, James. I'm just going to go back, Elaine, to one of your really important points about the fact that it is unique to everybody. There's been a lot of discussion around whether everybody should be offered bereavement counselling or whether you wait until there's a problem. And actually in the real world, it is probably that usual middle ground and being aware, as Elaine has pointed out, of the things which suggests that grief is not processing normally, if that's the right word. If actually there are complications, there's things that are going to make the emotional reaction much more heightened, that's then probably the time to trigger. But we don't know. People are fantastically unique, and they react to things in different ways.
And yeah, you're right. And I think almost thinking about a role in palliative care, when I first see a patient, I think you start that process from the initial assessment. So you start to look at the family members. How do they fit into the family? Is there potential for complicated grief? Do we need to act on it now? So kind of not leaving it till the bereavement stage, but thinking at the earliest stage, do we need to involve help for anticipating grief to prevent that complicated grief afterwards?
Absolutely, Elaine, you're right. It's part of that first assessment when you know, if you know that things are going to wind up. If it's an unexpected death, then you have to make that assessment very quickly. But then by definition, something that's unexpected is going to have a risk that in those remaining, it is going to be a more complicated reaction. But I think, again, think about COVID, think about being involved in care. When you can physically see what's happening, it's easier to think back and to process, and to, however painful and difficult it is, you can understand that the person was ill and was not going to get better. And that's what COVID has really put into sharp focus. I think Dr. Agnihotri had a hand up. I don't know whether it's possible to unmute your microphone. And I think, Claire, I think we can stop recording now.